Wonderful. All right. Well, welcome everyone to another edition of the New Brunswick Heart Centre weekly CV rounds. The year is shaping up nicely. I've got a good schedule lined up. Chris and I have lined up some good speakers for at least the next 8 to 10 weeks. So what I will do later this week, in addition to posting once again all the links on YouTube for all the previous talks, including the one from today, what I will also do is also try to put out a tentative list for what the upcoming rounds are, so people have a sense of the topics and the speakers ahead of time. I also want to try to stimulate some kind of engagement from the audience as far as speaker suggestions are concerned and topic suggestions. I think it's really key to have as many people involved as is possible in the shaping of these rounds so that they're useful for everyone. A little shout out to the 18 critical care students that are currently under the tutelage of Sue Morris and that are with us today from across the province. So once again, thank you for joining us. This is wonderful. And even though it says 30 participants, there's a lot of computer stations, for instance, the one in the OR with Monica, that have multiple people attending. So, you know, we've got upwards of 35 to 45 attendees, which is fantastic. So thank you so much. Last week's talk, Cardiogenic Shock, ABCs by Chris White. You will have seen the link on the email that went out. Feel free to share, feel free to subscribe to the YouTube channel. That was a great talk and one well worth revisiting to kind of keep up to snuff on the whole topic of cardiogenic shock. Today, I'd like to thank Dr. Jean-François Legare, both the head of the cardiac surgery program as well as the surgical lead for the TAVI program. He's going to give us a talk on the changing landscape of TAVI, a New Brunswick perspective, really something that kind of encompasses from 2010 till the present. So without further ado, I'll pass the torch off to Jaya. Thank you.
Thank you, Ansar. So I thought today I'd sort of review in my mind and to explain to you a little bit how our thinking around surgical treatment or treatment of aortic stenosis has sort of progressed over time. So it's not really a review of aortic stenosis in itself, even if we're going to talk about it in the background, but it's really what do we do for patients when they're referred to us with aortic stenosis. So all of this started essentially in 2010, where we used to think of non-operable or high-risk patients, and these were defined by classically an STS score, which means that basically a mortality predicted of about 10% or more. So these patients were then in a randomized trial published, shown that compared to medical therapy, transcatheter valve was associated with a survival benefit at 2 years. And that really started the use of transcatheter valve. And at the same time, there was another arm of the study comparing surgical aortic valve replacement with transcatheter aortic valve at the time. And the TAVR was shown to be non-inferior to SAVR in that population. Given the high risk of that population, it was clearly became essentially the standard of care at that time in 2010 and has evolved since then. This is a shout out to Mark Peltier, who you see here in this image, and this is some of the first transcatheter valve here at the regional, everybody in the room, patient asleep. There's Dr. O'Brien here with a transesophageal, and it really guided practice from 2010 to 2016, where in patients with aortic stenosis that were symptomatic, all patients with felt to be higher surgical risk were generally referred for transcatheter valve over surgical aortic valve replacement. And then in 2016 is where trials trying to test whether there was a difference in surgical versus transcatheter in moderate risk patients. And we define moderate risk as a risk of mortality predicted between 5 and 10%. And it was shown, again, that transcatheter was non-inferior to surgical aortic valve. And actually in 2020, I believe, or 19, this was a 5-year result that were published. You can see here on the curve that survival, so death or disabling stroke, comparing surgery versus transcatheter. So surgeries in red and transcatheter valve, they really course together. The curves sort of cross over at about 3 years, and surgery appears a little bit better in the long term, but is not significant at this stage, looking at in moderate risk patients. So that evolved our practice to this kind of practice from essentially 2016 to last year, where when we saw patients with severe symptomatic aortic stenosis, patients who were felt to be prohibitive risk or high surgical risk all went for transcatheter, really well accepted class 1 indication benefit. High risk surgical patients were still felt to be, could be transcatheter or surgical AVR, depending on the anatomy itself and what was most suitable for that patient. Again, class 1 indication. And now we had intermediate surgical risk patients where TAVR had provided some class 2A evidence for, and that obviously increased the number of patients who were felt to be moderate risk to undergo transcatheter valve over surgical AVR because of the low morbidity, obviously. But we still hadn't answered the question around low risk surgical aortic valve replacement or surgical AVR. So in 2019, the partner trial, low risk trial, was published. And this is an important trial because it really, while a smaller trial comparing about 500 patients or so between surgery and transcatheter valve, you can see the trial result. If you look at the 1 year death from any cause, they're essentially the same at 1 to 2%, not significantly different. So in low risk patients, that means less than 5% mortality predicted. The treatment appears to offer the same survival at 1 year. But if you included readmission for any reason in that, the surgery did not do as well as transcatheter valve. And that obviously opened the door for consideration for transcatheter valve or TAVR in low risk patient. I'm not going to go into detail of this trial because there are some controversies around that trial. Obviously, this was an older patient, so average age of 80. The difference was obviously driven by readmission, not by stroke or death, for example. And something that was a little bit unusual about the trial is about 20% or so of patients who underwent the surgical arm also had concomitant procedures, including root enlargement in a large proportion of patients, which obviously adds risk to the procedure and is a bit unusual in terms of the trial, but nevertheless, certainly demonstrated that transcatheter valve is a very good therapy for these patients and certainly of consideration in low-risk patients. So this is the body of evidence that we have without inundating you with other trials and other things. This is really the mainstay of evidence that we have so far. So how does that evidence, how do we include that in what we currently have? While the guidelines have not been updated, I've added some things to what we have. So now this all needs to be nuanced, and essentially there's evidence for both therapies in the intermediate and in the lower surgical risk patients. And you might quibble about exactly where that evidence is, and I'll try to narrow a little bit down how we think about it and how we then decide which therapy is most appropriate for one patient or the other. And as you can see, there's probably, while the intermediate risk, it's pretty clear that both therapies offer generally, and we would tend often to choose TAVR over SAVR. It's not so clear in the low risk surgical, in the low risk group. So what drives the decision? So how do we decide which one versus the other? I think in reality is we no longer think about it only about calculated risk. While 10 years ago or 5 years ago or even 3 years ago, the calculated predicted risk of surgery was something very important for us in terms of, okay, it's a high risk patient, then definitely is going to go for TAVR versus a surgical aortic valve replacement, for example. But that's no longer what drives. I think age actually of the patient is really what drives a lot of it at the present time. And so age of the patient matters. And the reason it matters is for many things. And one is that we don't have a lot of longevity data for transcatheter valve at the present time. That's the first reason. The second reason is you might choose a prosthesis by TAVR that you know is not going to last for a period of time, for longer than a certain period of time. You have to imagine what your next therapy is going to be. So in the low-risk patient who gets a transcatheter valve, their next intervention might be much more complex or complicated rather than the other way around, where you might choose a surgical aortic valve in which you can choose a TAVR after. Then the third reason is patients who do have borderline coronary disease. In choosing a transcatheter valve, there may be some technical challenges later from a percutaneous coronary intervention point of view in terms of negotiating the coronary anatomy, and we certainly spend a lot of time thinking about that. You don't want to be blocking potential therapies in the future. And then finally, we tend to now evaluate when we see patients, well, what are the inherent risks in this particular patient for surgical aortic valve versus a transcatheter valve? Can we actually, with the information we have, pick the best option for that patient? So the reality is in my mind is that we shouldn't be thinking of I'm referring a patient for surgical AVR or transcatheter aortic valve. I really feel we should be thinking I have a patient with aortic stenosis. They're symptomatic, and that's really part of decision one. Yes, they're symptomatic. Then they clearly need something done to that aortic valve. Then the second decision is what is the best approach for that patient. And in reality, we sort of three things that goes in our mind: the age of the patient, the clinical factors that might make you choose one or the other, and we'll go over those. And then the imaging modality that you're going to use to try to discernate which anatomy or particular features would make you think that one approach might be safer than the other. It's really about choosing the best therapy for the patient rather than competing options. So again, it's a balance of between transcatheter valve and surgical or aortic valve. I'm sort of, my sense of things is I don't see them as competing things. I see them as complementary things, a little bit the way as PCI and CABG surgery has evolved over time. There are clearly some patients in which surgical revascularization makes more sense, while other patients where PCI or percutaneous options make more sense. For aortic valve stenosis, it appears to be the same way. There are clearly some patients where transcatheter valve doesn't make sense because it's more risky for them, while a surgical aortic valve replacement would be less risky for them. And how do we do that? Well, in TAVR, generally older patient, because you don't have to worry about the longevity aspect or repeat interventions in the future that may be more risky. Clearly, a frail patient is a higher surgical risk, so assessment of frailty is helpful. I think higher surgical risk would make you tend to think more of a transcatheter valve because of the less morbidity and less difficult on patients in terms of recovery. And that goes with concomitant illnesses. On the other hand, the surgical aortic valve, you might be tempted to in a younger patient, and we'll discuss how do we define what is a young patient and where is that cutoff, and that cutoff will likely change over time. I think coronary disease is an important one. I think if a patient has prognostic lesion on their coronary anatomy, such as left main or proximal LAD disease, it makes more sense to offer revascularization and surgical aortic valve at the same time. And that's some of the discussions we would have. But in an elderly patient with non-prognostic coronary lesion, you might choose to ignore that obtuse marginal or circumflex graft or disease and just deal with the aortic stenosis with a transcatheter valve. Bicuspid valves can still be challenging with transcatheter valve, and there are some features of some bicuspid valve with, for example, bulky calcification, which makes a TAVR difficult, and sometimes we cannot do. And the leaflets sometimes are very high. They may obstruct the coronaries if you push them out of the way, and we'll review that. So bulky calcification is one that's a little subjective, but it clearly sometimes in someone who has very, very heavily calcified aortic valve, we worry about the valve that you're going to put in there not conforming properly and have paravalvular leak issue in TAVR. So you might favor a surgical AVR in that setting. Poor vascular access is still very important. And we look for vessels that are more than 6 millimeter, for example, in the femoral. And the reason for that is that all of the benefit of transcatheter valve tends to be in the transfemoral approach TAVR rather than the alternate approach TAVR. The alternate approach TAVR, so whether you would go direct aortic or axillary or other aspects, they tend to do as well as the surgical. So why not do the surgical if we're going to do low risk and moderate risk patient? And that's been our philosophy here. And finally, the coronary height is very important because we don't want to obstruct the coronary anatomy when we push the valve out of the way when we do a TAVR. And this is what I mean. So these, and CT imaging has really been key in making the decision making. So in the image on the left here, I show you where the calcium is on a valve. This is actually a prosthetic valve, but you can imagine that this is a left main. The height of that here is measured at around 8 millimeter. And you can imagine that leaflet here would get pushed up and would actually obstruct, would actually obstruct the orifice of that left main. So this would be a very high risk transcatheter valve. And in that patient, we offered surgery, not a TAVR. It did not make sense to put that patient at risk. And there's really not a lot of intervention you can do. I mean, there's techniques in which you put stents in here with a chimney going up, but these are all suboptimal options, at least in the current environment. So the CT scan is very helpful in sorting that out. So not only the space allows you to see the space, the alignment, and whether the height is okay. And the same is if you imagine a large piece of bulky calcium right here, the valve would sit and would push, but it'd be hard to get a proper seal with a bulky calcium and have a power leak risk. The same as a bulky calcium can actually, once you balloon expand, can actually rupture out, and this is where you get a rupture. So we try to avoid that risk. On the CT scan on the right, you can see here a very nice bend. I mean, this is an 180 plus degree bend of that aorta in the arch. This was, this was an 84-year-old patient who was not a high-risk surgical patient, but clearly from a transcatheter point of view, this would be very challenging to negotiate that curve. So she ended up having a surgical aortic valve replacement. So these are the kinds of decisions you end up making when we refer patients to us. So how has the TAVI program evolved at the New Brunswick Heart Centre? Just to give you an idea of the numbers, in 2010, there was about 9 patients done, to be exact. And we've grown up to last year, I believe 91 or 92, and this year we're on pace for 120 or so transcatheter aortic valve. So the TAVI program has grown every year. Mortality is low. That includes even the high-risk patients in the early years. And day 1 discharge currently is more than 60% of our patients. So this is what we aim for. You can see that the morbidity and the mortality is obviously quite low, and obviously a worthwhile effort and approach for many of the patients in which we choose. So how does that look like in terms of our entire surgical volume, or the volume of aortic stenosis that we deal with at the Heart Center? This is looking at numbers, and these are all aortic valve procedures. I don't have 18 and 19, but it's around 250 or so aortic valve prostheses that are put in at the Heart Center on a yearly basis. And I've told you that now we're approaching 120 or so from a transcatheter valve point of view. So that's nearly 45% or so of all aortic valve replacement being transcatheter valve. And in terms of isolated aortic valve, it's more than 60 to 70% of them that are transcatheter valve. So it's obviously taken a large chunk or a large portion of our of what we do. But I believe that we are evaluating them and sort of trying to judge what is best for every patient as best as we can as we move forward. So what does this mean for my patient with severe aortic stenosis? So this is, when I see them and patients are referred for us, I tend not to think of them initially as, first question I have is, do they need an intervention, meaning they're symptomatic? So if they're symptomatic with aortic stenosis and the classic symptoms still apply, and it has to be severe aortic stenosis, we certainly do see our share of moderate aortic stenosis. I don't know what to do for moderate aortic stenosis, and sometimes they're very difficult to sort out. And the same is patients with severe aortic stenosis and no symptoms. I'm not sure always what the right thing to do, even with some trial evidence that I'm not going to bring forward here in terms of decision making. But clearly, the way I think of it is patients that are older than the age of 70, I'm more likely to look for comorbidities and issues and things that would make a surgery for them more risky than I would try to think and see whether transcatheter valve makes more sense. And then I would arrange the CT scan to help me. In patients that are younger than 70 years of age, in which I think they have a likelihood of longevity here more than 10 years, then in that setting, I'm more likely to consider and to have for surgical aortic valve replacement, and be thinking also about the other things that I'm thinking about, prognostic coronary disease, the vascular access. If they're bicuspid aortic valve, it pushes me more towards that way also. Same for the bulky calcium and the coronary height. So CT scan is sometimes helpful in that setting if you're uncertain. So it's the patients in the middle that's sometimes a little bit gray, but the younger you are, the more likely you should have a surgical aortic valve. That's the standard of care. The older you are, the current standard is really for transcatheter valve. So the reality is, we are doing things differently and we need to evolve, and we've really shown lots of evolution over the last 10 years or so, and it's going to continue to change. Thank you, Ansar.
Great, thank you, JF. That was an excellent overview of the program. I think we would all agree that the TAVI program has been a real example of multidisciplinary success. I mean, combination of cardiac surgery, interventional cardiology, interventional radiology, anesthesia, nursing. I mean, all since day one, which is I think fantastic. So, and we've been up until this point, I think, growing because of that interdisciplinary model. So, and I think you've written something in the literature to this effect, but I think we've definitely been an example for many centers across the country. Quick question, and then if anybody has any questions, feel free to either unmute themselves and/or use the chat box. Either technique works. Question, Jeff. Just so we've recently moved to a model whereby even if somebody is being sent specifically for a TAVI, they're seen by the on-call surgeon that week while they're being worked up. Maybe like especially for some of our referring cardiologists, internists that are on the line today, do you want to maybe explain the rationale behind that?
Yeah, I for one is I think all of us from a surgical point of view are dealing with aortic stenosis all the time. We're very well trained in what we think is understanding of what the risk to a surgical patient is. So I think it's really important to maintain every single surgeon engaged in terms of being able to assess what is truly the risk for that patient, because it is still part of the discussion and the decision making. So in that setting, my colleagues, if they judge that patient is obviously higher risk, then it makes sense then I understand better and they understand better the process. Okay, so let's think about TAVR in this setting, and then it's circle back to transcatheter valve team, which then looks at the patient. In the same manner as many patients that are referred to us, as I alluded to, where vascular access is an issue, left main height is not right, then it makes sense that we refer back to that, referring to my colleague who's seen that patient already and has that rapport and that relationship with that patient to be able to offer them surgery and they've already talked about. So that's part of the reason. So we're maintaining everybody as part of that team. So all the surgeons are involved. We do have a little specialized group of us from a surgery point of view, Dr. Pozek and myself, and obviously on the interventional cardiology side that are particularly interested in this. So we meet on a weekly basis, twice a week actually, and discuss patients. We discuss about we're trying to aim for 9 to 10 patient discuss every week. So it gives you an idea of the volume that we see, just to decide on best options for them. And not everyone who comes to us is therefore necessarily going to have a transcatheter valve. Sometimes it's, oh, we're going to wait a little bit, we're not certain. Sometimes the aortic stenosis is not that clear, we need to sort it out. And sometimes I think surgery makes more sense here. And then sometimes obviously transcatheter valve makes more sense. So that's how we approach it in general. So hopefully that documentation comes back and circles back to you, because I dictate all those notes. So please let me know if you don't get those dictations. So sometimes I think we've been certainly better at doing that in the recent past. So it's been working as a system.
Excellent. A couple of questions that have come through on the chat. First one from Dr. Forgy, who actually used to be one of the co-surgical leads for the TAVI program here at the Heart Center. Question about pacemakers. Post TAVI. Once upon a time, it felt like we were doing a lot more. Can you talk about sort of the ability to predict how you guys approach people who may be at high risk for a pacemaker post TAVI? And then secondly, just in general with low risk patients, in our sort of pendular shift towards that population, the potential complication of a pacemaker implant in that population seems a little bit dicey and prohibitive. What are your thoughts on that?
Yeah, it's an interesting point Rand brings up, is there's no doubt that long-term survival in patients who require a pacemaker is probably lower than patients who don't, which makes you think that if you could avoid a pacemaker, maybe you would actually improve their long-term survival. So in that context, there's clearly patients that are higher risk for pacemaker at the time of TAVR, and TAVR in general would carry a risk of pacemaker insertion of between 8 and 12%, which is much higher than surgical aortic valve replacement. So in a young patient in which from everything else they could have either, and you felt there was a very high risk for needing a pacemaker peri-procedure, you might want to choose a surgical aortic valve versus a transcatheter valve. So sometimes that's part of that discussion, but it is something that's evolving. How do we approach it? Essentially, from your point of view, anybody with a right bundle branch block is a very high risk for needing a pacemaker at the time of a TAVI. Bottom line, because at the time of transcatheter valve, we virtually always affect a little bit the left bundle, and the left bundle will be prolonged, even if it's for a short period of time. But if it's prolonged for a short period of time and you have a right bundle, you're guaranteed to have no bundle at the end. And no bundle ends up in a permanent pacemaker. Is as simple as that. We've looked in our data for the risk factors. The risk factors come out as such. Anybody who has bradycardia under 50 as a rate, anybody who has a QRS duration of more than a very wide complex, and anybody with a right bundle are the three things that are the biggest predictor for needing a pacemaker in our population. And for us, the overall is 9% currently for everybody for needing a pacemaker.
Wow, excellent. A couple of more questions here. First is, any thoughts on the use of TAVI in the setting of AI? I know generally speaking, we've steered clear of people with AI as the primary pathology, you know, some aortic root slash ascending aortic dilatation, but are we kind of, as technology has improved, is that patient population potentially going to come back into the fold?
Yeah, there's no platform currently that we use or that's clinically available for pure AI. There's none. There are some things in the works in terms of potentially looking at that, but you rely heavily on the calcium of the valve for the framework to hold there. So without calcification, so you may have a lot of AI in somebody who has a mixed AI-AS, that's not a problem because the valve's calcified. But if there's no calcification, and sometimes we get referrals for that, you know, patient with primary AI, no calcification, we cannot. It will not work. So that's a no for sure, 100%.
Ashley, go ahead. You can unmute yourself and ask
Okay.
away.
Yeah, I just had a quick question for JF. What are our numbers and how do you think we're doing compared to the rest of the country? Maybe more importantly, with respect both to GA versus sedation and percutaneous versus cut down.
Yeah, in general, we're ahead of the curve. Most centers, so there's lots of mounting evidence that conscious sedation and percutaneous approach are safe, and not only safe, probably associated with better outcomes. And we're nearly 100% conscious sedation percutaneous approach. I don't remember the last time we opened a groin to put a TAVR in. And in terms of GA, it's, you know, once or twice per year in a very sick patient. So generally speaking, we approach everyone, and that's been, you know, we didn't explore all the little details of this, and that's been a big endeavor by, I thank you, Ashley, for pushing that agenda, where we were trying to stay away from getting to intensive care unit. We don't even recover them in ICU. They basically get the procedure awake. The procedure lasts under an hour. They go to a cath bay, and they're upstairs to the floor within 40 minutes after.
Last question, and this is a good way to sort of sum it all up, from Mahmoud, one of our assistants. Do you see TAVI expanding into the under 70 age group? And more importantly, do you just see it becoming the gold standard for aortic valve disease or aortic stenosis in the near, not too distant future?
Yeah, it's hard for me to predict. If, you know, if I look at the history of how it's progressed, there's no doubt in my mind that it's going to continue to expand and grow. What really is important for us is not to get caught in a system where, oh, it's doable, we should do it. More, let's really make sure that we choose the best therapy for that patient. And I think we've approached it that way. And that's why, while it's growing, I think it's growing in a way that's appropriate at the present time. And as long as you work as a heart team and we discuss these patients and choose what's best, I think it's going to work. If you didn't work in a heart team setting and a discussion, then I think, you know, anything's possible. You could have a very strong surgical group where all these patients actually would go to surgery rather than transcatheter, or the opposite. And I'm not sure that's best serves patients.
Yeah. Well, JF, thank you so much. That was a great talk and a great discussion. Until next week, in the interim, as I said, I will put something out later this week with a kind of a preliminary schedule for the next month or so, and as well as a copy of today's session. Thank you, everyone, and thank you very much, JF. That was a great talk.
Thank you.